A different way to think about hip physiotherapy. Hi, my name's Nell Mead. I'm a physiotherapist with my own private practice in Liverpool Street, central London. I started off as a physio in the British Army, and I did that for 10 years, spending my last 2 years in Cyprus as the head of physio and rehab team for British Forces Cyprus. And while I was out there, I also became the physio for the Cyprus Davis Cup tennis team. When I came back to the UK, I left the army and set up my clinic, Victory Health and Performance, which I ran for another 10 years. In 2013, I did 9 months of fairly intensive training with a pioneering Canadian physio called Diane Lee. She taught me a whole new perspective on looking at human bodies, and I've been using that ever since. And I now specialise in helping people with complex and long-term problems. So hopefully, over the next half an hour or so, you'll start to understand some of how I do that. So what we're going to cover today, well, Vipin asked me to talk about physio for hip injuries and suggested that I do a bit about arthritis, hip replacements, FAI, and how I treat each of those. But that's not really how I work. So with his permission, I'm going to talk about what I actually do. Physios and surgeons do look at the body in different ways, but physios and physios also look at the body differently, and so do surgeons and surgeons. You know, you like different kit, different approaches, different attitudes to post-op protocols, all that sort of thing. So I'm going to start off by looking at about some of the different ways that different clinicians look at bodies, a little bit about evidence-based practice. I'm then going to talk about relationships between doctors and physios, not boyfriend-girlfriend relationships, the importance of building professional relationships. And then I promise I will actually talk about hips and how I assess and treat people with sore hips, with a couple of case studies to finish up. Okay, so let's get on with it. We look at bodies differently. Our roles are different, surgeons and physios, so it's no wonder that we look at bodies differently. I sat in with one of my favourite consultants a few years ago, and he was telling me all about all the advantages that surgeons had over physios. You guys dictate your letters rather than write your own notes. You have imaging on tap, especially if you're in private practice. And while he had a point, from my perspective, we simply don't do the same thing. So when you guys intervene with a patient and you operate on them, the effects are permanent, good or bad. So you need to make sure that you get things right the first time. When I work with a patient, I have to work with them, not on them, because I can't make permanent changes for them. I have to teach them how to make permanent changes in themselves by getting them to change their movement habits. I also have to think about more about how the painful area integrates with the rest of the body, because my job is to get the patient moving normally again. And it's not just to get the sore bit working better in isolation. But I'm very keen on surgeons who specialise in one body part, because when I send my patient to a consultant for hip surgery, I want to know that you're fantastic at hips, not that you're quite good at hips, shoulders and noses. So I'm not saying that either role is better or more important. They both have got their place, but they're quite different. And so the models or the lenses that we use to view the body should be different. So let's have a look at a couple of those. So the first one is the biomedical model, which is probably the model you're most familiar with. Effectively, it says that health is the absence of disease, pain or defect. And from an orthopedic perspective, you take a history, you look at your signs and symptoms, you do your standard orthopedic tests, and you come up with a diagnosis. Is the painful tissue bone, cartilage, muscle, tendon, etc.? You find the tissue that hurts and you treat it, whether that's with physio, injection, and operation, and then you strengthen it. And there's a physio I particularly dislike, whose mantra is you can't go wrong getting strong. I don't totally hate the biomedical model. It's relatively straightforward, and a lot of the time it works. It's actually pretty good for orthopedic surgeons, probably more so, I think, than for physios, even though most physios still follow it. But it only works about 70% of the time, which I think is quite a high failure rate. Then there's the regional interdependence model, and this is a model I much prefer, especially from the physio side, because essentially this is about kinetic chains, and it's a bit like chaos theory. You know the saying where a butterfly flapping its wings can set about a chain of events that causes a typhoon on the other side of the ocean. Well, we get taught at university that if you've got a patient with a sore knee, then you should look at the joint above and the joint below. And even though we never really got taught what to do about it if we did find something wrong there, it's true, a dodgy hip or a stiff foot can affect the knee. We know this, we accept this, yeah? But what about the joint above the hip? Could a stiff pelvis cause a dodgy hip that upsets your knee? Could a twisted thorax cause the stiff pelvis that causes the dodgy hip that upsets your knee? What about an old whiplash injury in the neck? Could that cause the twisted thorax that causes the stiff pelvis, that causes the dodgy hip that upsets your knee? This is starting to feel a bit like an old Rolf Harris song that we probably shouldn't really be talking about. But yes, essentially, yes, it could, but you'll only find it if you know how to look for it. So in this situation, when I'm using the regional independence model, you still can do orthopedic tests, but you're not necessarily doing them for the same reason, unless the orthopedic test is really relevant to the patient in front of you. So from my perspective, I think I'm better off doing something more functional that really relates to when the patient experiences their problem. So when you're viewing the body through the lens of the regional interdependence model, you're not looking for the pain generating structure. You're not looking for the what. You're looking instead for the why, the underlying cause, which may be the same place or it may be something totally different. So this is why I don't believe that physios should have protocols, because the pain generating structure, in my view, is a symptom, not a diagnosis. So that would be like having a protocol for treating a sneeze without knowing whether the sneeze is caused by hay fever or a cold, or whether somebody's just stuck a load of pepper up your nose. Anyway, if the biomedical model can help about 70% of patients, then most of the other 30% could probably be helped using the regional interdependence model. Only most clinicians don't know about it, and it's a bit more complicated and time-consuming to practice. And then there's my model. So this is the one I actually use. I don't start off with doing physiotherapy at all. Let me find my laser pointer. So I start off down here. I start my patients off by looking at their tissue health. So if you're not on top of your sleep, stress, hydration, nutrition, then your metabolism will be poor at the cellular level, and you won't benefit as much as you might do, even from high quality physio. So that's the foundation layer. I start with that. Next, I've got the sort of pinkish health layer, the alignment by biomechanics control, ABC, which is a way of explaining that regional interdependence model. And once I've got those sorted out, once the patient is aligned, biomechanically sound, and they've got some decent motor control, they should be moving better and they should be heading out of pain. Then we've got the purple performance layer, which is about injury proofing to reduce the risk of the injury recurring. So we look at strength, we look at flexibility and endurance. And then finally, if the patient is sporty, I can liaise with their PT or their sports coach to look at their technique and give them technique drills so that they don't go back into their old movement patterns as soon as they get back onto the court or onto the pitch. So you can see that I like to be quite thorough. Don't want the pointer anymore. Go away, pointer. Thank you. Have the clicker back. So evidence-based practice is always the elephant in the room whenever you talk about anything like regional interdependence. If there are no protocols and everyone gets treated like an individual, where's the evidence? Well, evidence-based practice in many circles, oh, wrong way. How do I go back? That way. So in many circles, evidence-based practice is being treated like this. We shouldn't start using interventions until there is sufficient evidence for them. Well, okay, but that doesn't give us very much scope to do anything, because I don't think I've ever met a patient who meets all the criteria for any RCT I've ever read. Does that mean I have to stop treating everyone until a suitable RCT has been carried out that fits them? Well, the original definition of evidence-based practice is this one on the left. It incorporates the patient's values and goals, it incorporates the research evidence where appropriate, and it incorporates clinical expertise. Clinical expertise is defined as skill acquisition, which is how to do the techniques in your toolbox, plus clinical reasoning, which is how and when to apply those tools. So it refers to the clinician's proficiency and acuity when making judgments and applying clinical skills in the care of individual patients. And my favourite quote on this matter is from Professor Gwen Jal, who says, "The future continues with an informed, clinically reasoned assessment approach to the direct management of the individual patient. In other words, N equals 1. But why not just treat the diagnosis? Treating the diagnosis is exactly what the earlier editions of Bruckner and Kahn and all the sports medicine and physio techniques did try to teach us. Make the diagnosis and treat that. And it's still really widespread. But physios as well as surgeons need to treat the patient, not the scan. We know that two patients with similar looking imaging can have completely different experiences of pain. And that's because they've got completely different nervous systems, which have been shaped by their past experiences. Moving on to clinical relationships. So hopefully you're seeing by now that just as not all surgeons are the same, nor are all physios. So on that note, this down here is my model of how to get the best outcome for a patient. So as you can see, I've got three main elements of a great outcome. I've got a great surgeon, a great therapist, and a great patient. And where they overlap is the relationships between them. The sweet spot in the middle, in here, is where all parties are contributing optimally to the patient getting well. So that's where you've got the best odds for a great result. And that's not just me talking, that's backed up by research. In fact, there's a BMJ paper from 2009 that explicitly states that patients' trust in their doctors, and by extension their therapists, is absolutely fundamental to an effective clinical encounter. So if it's at all possible, I would strongly urge you to choose your therapy partners wisely. Get to know them and understand how they work. Let them get to know you. Otherwise, you won't have a clue what happens to your patient from the moment they leave your theatre. And even if you can't get to choose your therapist, get to know them. I'm a massive fan of coming into theatre to watch my patients having surgery, because that, as far as I'm concerned, is where the baton of care is passed over from the surgeon to the physio. But it's also vital to keep communicating while the patient's getting better, and to include the patient in their own care, because most of the time the patient's on their own. The best patient outcomes are based on trust, and trust is engendered by strong positive relationships with all the stakeholders, surgeons, therapists, and patients. So if you really care about your patients and their outcomes, please don't leave it to chance. Get to know the best therapists in your area and give your patients the optimal opportunity to make a great recovery. So how does all that relate to hips? Intro over, I promise I'm going to start talking about hips now. So what are hips for? Why do we even have hips? Well, we'd struggle if we didn't. We'd never be able to pick anything up off the floor or sit down. So I'm quite glad they're there. But seriously, hips need to be able to move, possibly a lot if you're a Cirque du Soleil performer, maybe not quite as much if you're an office worker whose main exercise is going for a bike ride at the weekend. Hips also need to be able to bear and transfer load without collapsing on you. And they need to be able to do both of those things while you're concentrating on doing something else. In other words, you need to be able to walk and talk at the same time. So what does optimal function require? Well, if you want to be able to walk and talk at the same time, or maybe do the splits, then there are a few things that you'll want to have in place. So you'll need decent structural integrity to start with. I don't necessarily mean that the shape of your bones needs to be perfect, but there needs to be enough bone to allow for stability, in enough space to allow for movement. You want the labrum to be stable. You want the ligaments to be intact. You need your mechanoreceptors to be in decent working order so that the head of the femur stays in the acetabulum. And your nervous system needs to be telling the right muscles to switch on and off at the right times and with the right amount of oomph. If the patient doesn't have these and it's causing symptoms, then pretty much the structural integrity part is your problem and the rest is mine. I thought I'd stick this slide in because I don't know how things work with you guys, whether you're NHS or private, but where I am in private practice, assuming the patient hasn't gone to A&E, a patient can present first to their GP, their orthopaedic surgeon, or their physio. So any one of us could be the first contact for any injury, pretty much. Obviously, in this situation, the first thing is to work out who will be best placed to deal with this case at the start. So if I'm the first contact as a physio, I'm asking myself whether the patient needs to see an orthopaedic surgeon first, or to have any further investigation that I can't provide before I start treatment. So that means I need to be aware of orthopaedic red flags, but also potential non-orthopaedic differential diagnoses, and to exclude them as well as I can. Hopefully you guys will all be aware of these, so I'm not going to teach you to suck eggs by going through them. But what I would say though, is that the physios in your area should be aware of when to refer on to you if it's necessary. But you also need to know that not every private practice physio these days has gone through an orthopaedic rotation like we did back in the old days. So although they may be really comfortable with how to treat a patient, and hopefully they are, they may not be super comfortable with how or when to refer. The orthopaedic practices in central London run regular CPD events where the consultants go through these sorts of issues and case studies, and they talk about when to refer. And I must say, it's an incredibly useful resource, especially for the newer physios. So if you ever get the opportunity to get involved in those events, it's a great way to start building relationships. But essentially, we're looking at, if the first contact is a physio, if that's me, I'm looking at a differential diagnosis. I'm looking at, when do I refer immediately to an orthopod or to A&E, if there's trauma, deformity, non-mechanical symptoms. If it's later on, if I'm thinking, well, I've done a couple of sessions with the patient, they're not really responding, or I've done a couple more and I just don't think we're going to get a satisfactory outcome without getting an orthopaedic opinion. I think they might need surgery. I'm going to send them on to you guys, but I'm not going to send them on if I can resolve the patient's symptoms to a degree that they're happy with. And I'm not going to send them on if I can teach them strategies to remain functional and pain-free going forward. Subjective assessment and goal setting. So I know you guys know how to do this from an orthopaedic perspective, but as physios, we should be looking at it from a slightly different view. I want to know what the patient's experience is. I want to know about how they move. I want to know about their beliefs. I want to know how much time they can devote to their rehab and what they want to achieve. One of the things that I hear a lot is, I've never been right since. Whether that's, I've never been right since I fell down the stairs when I was a student. I've never been right since I had really bad appendicitis. I've never been right since. So it's one of the phrases to really look out for, because it's amazing how often that sprained ankle or that broken collarbone that happened years ago has gradually created altered movement patterns that have led to the issue that they've come to me to seek help for. I'm unusual in that I spend at least 90 minutes on an assessment session, which does let me get in pretty deep. And for me, the subjective can sometimes take an hour, possibly even more. So I'm going through all these things. When, what are they feeling? When do they feel it? What else is going on for them? Have there been any major emotional events that have triggered things for them? And then I'm reflecting back to them. I'm hearing you say that you've got this problem when you do that thing. And if you had £1 million, you'd like to be able to do it better. Okay, let's go in and work out what's causing this. That's how I end up subjective every time. I then move into the objective. Now, again, this is going to be different for physios than it is for orthopaedic surgeons. So once I know what discomfort they feel and when they feel it, I break that task down into its component parts and I test the component parts. So for example, when you walk, the component parts include weight transfer from one foot to the other. They include stepping forward onto one foot. They include a thoracic rotation and they include an arm swing. And throughout the task, the movement should be optimal, which essentially means that it should look good and feel good. The way that it becomes able to look good and feel good is exactly this. So it will have optimal alignment, biomechanics, control, ABCs. So I need to know what the biomechanics of the task should be and work, and then look at what they really are. Optimal strategy should distribute and balance pressure evenly in the canisters, the cranium, the thorax, the abdomen. So the patient should be able to breathe. They shouldn't start to feel that they're building up pressure in their head. They shouldn't, they shouldn't wet themselves, for goodness sake. They shouldn't feel, pressure in the pelvic floor. They should be able to accommodate perturbations. So if you're standing, if your problematic thing is standing, I should be able to give you a gentle shove as you're standing, and you shouldn't just fall over. So you should be able to accommodate, a little bit of resistance in different directions. And then this is why I look at the movement that they actually do. It's really important for me to see, not just to hear what tasks they have problems with, but to watch them and feel them doing them. Because then I can feel the things that go wrong, not only in the painful area, but in the rest of the body as well, because body parts don't work in isolation. Everything's corrected. So I watch them and I palpate as they do their task. I find the areas that aren't moving optimally during the task, and then I support and facilitate each non-optimal area in turn. And I correct them to find out which area, when I correct it, gives me and the patient the biggest change. So what helps the most? When we find the best area to correct, we call it the driver, the thing that's driving the problem. And then it's pretty cool. The patient's body relaxes. They feel like they're moving more freely. Suddenly the movement becomes less painful, it gets easier, and they're just like, wow. So in my objective assessment, I'm looking for a wow. And the relevance to hips, so specifically for hips, as I mentioned, I want my tests to be relevant to the patient. So I usually base them on a movement or activity that the patient either hasn't been able to do due to pain or wants to be able to do for another reason. So maybe it's a yoga pose that they want to be able to achieve, but they feel like their hip's stopping them, because not all my patients are in pain. So there are some fairly standard tests I tend to use with patients who are complaining of hip pain. So common ones I will use might include a squat if they're struggling with sitting down or standing up after sitting. So I could use going down into a squat or coming back up. It could be a weight transfer. So if they're struggling with walking or running or something like that. It could be a seated or standing roll down if they're doing things like struggling to touch their toes or struggling to put their socks on or cut their toenails. These are all things that patients with hip pain commonly mention. But if their issue isn't a standard issue, I might use a completely non-standard test, something that's really specific to the patient. For example, I've looked at, or I've palpated how the hips move in various yoga positions. I've looked at how they work in golf swings and tennis serves and so on. So the point is that the test, for me, has to be relevant to the patient. And then I'm working out, is the problem really coming from the hip? Because I'm not looking just at the sore hip when they do all these tasks. I'm observing and palpating the whole kinetic chain, looking for areas that aren't moving as they should. And remember that as they should doesn't mean there's only one possible technique. Roger Federer's forehand, Rafa Nadal's forehand, they're about as close to perfect as you can get, both of them, but they look completely different because each forehand is optimal for its owner's body. So it looks and feels good, it's balanced, it's biomechanically sound. Both forehands are great, but they are different. So I'm not saying that everybody should move the same, that you should move well for your body. And when I found areas that aren't moving well for this patient's body, then I can use my hands to support and correct the movement patterns and see what effect that correction has on the rest of the body, especially the hip. Now that's really hard to visualize, so I've made some vids that I will play now. So here we go, this is me correcting a thorax. So, Liz is a yoga teacher and she's got really great body awareness. So we're going to use her to see if we can feel whether changing the other things, other body areas of the body makes a difference to the hips. Now, standing behind Liz right now, I can feel, I'm looking at her thorax and I can feel that she's tighter and more compressed on this right side, which is dropped down relative to the left side. And there's a slight rotation, so she's slightly further forward on the right side than she is on the left. Liz, I'm going to get you to feel your hips for this one. Can you place your hands on your hips? So that means right at the front, so down a little bit, yeah, right to there. Can you feel the head of femur just there?
Yeah.
Yeah? And does one side feel further forward than the other side?
Yes.
Which side feels further forward?
The right side.
The right side, perfect, I agree. So what I'm going to do, I want you to keep your hands there throughout. I'm then going to get you, I'm not changing anything here, I just want you to go down to a little tiny squat, so just bend your knees for me a little bit, that's it, and then come back up. And as you go down this time, I want you to feel for those hips and see whether they are staying straight or whether one side is going further forward as you go down.
The right side is going further forward.
Right side is going further forward. So we know that your right side starts further forward, and as you go down, it continues to go further forward, yes?
Mm-hmm.
Okie dokie. So what I'm going to do is change the orientation of your thorax and see whether that makes a difference to your hips. So, here we go. So take a big breath in for me. And then as you breathe out, I'm just going to very gently lift your thorax. Perfect. You can feel that lifting. I just want you to breathe gently while I just wait for your nervous system to tap into that. That's it, that's starting to release. And then just reset your feet for me. So just march on the spot. That's it. Perfect, lovely. I'm then going to start being more specific, coming into there, and can you feel I'm offloading that right side in particular? And so you're untwisting there, and your body's starting to take on the changes I'm making. Okay, another little march for me, just reset those feet. Good, perfect, okay. So we're going to hold you here, I've got the full correction in your rib cage. I just want you to go back down into that little squat again, and then come back up. Good, okay. So starting position in standing, do you now feel as though one hip is further forward than the other?
No.
Okay, so we've realigned your hips in standing. And then if you go down into that little squat again, does one hip drop forward? No. Oh, good. And back up. So we've changed the alignment in standing and we've changed the alignment in the squat. I'm just going to let go. And you feel that you drop back down on that right side. There we go. And that's it. We've made a change. So what's interesting for me there is that I can see how little movement it really is, because when I'm actually doing that, it feels like I'm doing quite a big correction, but actually you could hardly see my hands there at all. So what I was doing was just very gently lifting up the rib, particularly on the right side, but on both, just to create a little bit of space, and then just drawing the rib back, just following the line of the rib, so just stacking it above the rib below it, so that we're trying to get the thorax really stacked like a Jenga block. So that's how we correct the thorax. So it's just stacking the ribs on top of each other so that you're aligned on both sides. That's correcting the thorax.
So
then let's move on to correcting the hip. So let's see if this one works. This one is going to be correcting directly the hip joint. So this would be much more similar to the biomedical model, because in this instance we are looking at whether the hip is actually both the driver and the pain generator. So here with Liz again. This time we're going to look at her hip and see whether we can influence her hip mechanics directly from the hip. So Liz, can you put your hands just over the front of your hips again? Lovely. Can you feel that one side is further forward than the other?
Yes.
And it's still the right side that's further forward?
Yes.
Lovely. And then just go into that mini squat again and come back up. And does that right hip still slide forward as you do it?
Yes.
Yeah, okie dokie. So there's our baseline. I'm then going to correct the hip position. So if you can just go up onto the toe on this foot and take your weight onto the left foot. That's the one. I'm going to put my left hand, the back hand, on the ischium. And I'm just going to lift the ischium slightly so that I'm effectively lifting the socket off the ball, if you like. With the right hand, I'm just going to come behind your hand there. So I'm getting into the head of femur. I'm just going to, as you bring your heel back down, I'm just going to slide that head of femur back into the acetabulum so that it's really centred there. That's the one. Bring that heel right the way back down, weight evenly on both feet, and then just a little march just to reset your feet. Perfect. Okie dokie. So first of all, can you feel that hip is now in a slightly different position? Excuse the dog walking part.
Yes.
Yeah, yep. Lovely. And then just go down into that mini squat again. Good. And can you feel that staying centred all the way? Because I've got full control on that hip. Lovely. Yeah. As I let go, can you feel that just sliding back forward and down again? Okay. So that just shows us how we can manipulate the hip position directly from the hip joint. So what you can see from that video again is just how much we're not influencing the musculoskeletal system particularly as much as we're influencing the neuromuscular system. So it's all about really giving input into Liz's tissues just to encourage her to move in a slightly different way. I'm not forcing it, I'm just giving a little bit of support. And then I've got one more, which is the other really common place to intervene. So here with Liz again. No, not that one. The other really common place to need to intervene is in the foot. So here's me intervening with Liz's foot to try and affect her hip. So this time we're going to try and correct Liz's foot and see whether that makes a difference to her hip position. So Liz, can you pop your hands on your hips again and just make sure of that baseline? So first of all, does the right hip still feel further forward?
Yes.
Lovely. And then go down into your mini squat and then back up. Okay. Does that still feel as though that hip's going further forward?
Yes.
Okay, now what I'm looking at down here is your foot position. So what should happen as you go into a squat is that the big toe and the arch should lengthen. So just do that mini squat again for us. And what we can see is there's absolutely no movement in that foot as you do that squat. So it'd be really interesting to see if we can do that. The other thing I'm noticing, come back up again for me, is that the talus is slightly everted. So the talus is slightly on the outside. It's not pointing straight. I'm just going to interrupt that video there for a second because I got that wrong. The talus is actually slightly inverted at that point. So yeah, think about that as we're going through this. Okay, let's crack back on. Straight down along the foot. So it's almost, the centre of the talus is almost sort of over third ray instead of second ray where it should be. So we're going to see what we can do to correct that. So if you can just come up onto the toe once more. That's it. And I'm going to just traction the subtalar joint here and pull that down so that we're creating a bit of space through here, which will hopefully do something to that talus. Then as you bring that heel back down, just slowly bring that heel back down again, that's it. So I'm just guiding the subtalar joint, guiding the calcaneus into position, guiding the talus into position. That's it. So I've got your foot there, lovely, little bit more in a good position. And just lift that left foot up and down once, just to reset the nervous system. That's it. Perfect. Okay. So we've reset the system so that it can now accommodate the change I've made in your right foot. And now what I'd like you to do is just take your hands on and off your hips and just feel, is your right hip still further forward?
No, I don't think it is.
Okay, interesting. And then come down into that squat again. Good, and back up. And could you feel a difference in the hip compared to without me there?
Yes.
Yeah? How did that feel? Better, worse, or same?
It feels better.
Better with the foot position corrected?
Yeah.
Lovely, okay. And just go down again, and this time we're going to be watching your arch. I want you to try and really lengthen through your big toe as you come down into that squat. Okay. And back up. So even though it feels better in the hip, we're seeing that the foot mechanics aren't changing dramatically. It feels as though there might be something going on that's more sort of jointy around the foot. But there we go. So we know that we can change the mechanics of the hip by changing the position of the foot. Okay, so we've seen that we can alter the hip mechanics and the way that the hip feels by correcting any of the three areas of the body that we tried. So we went through thorax, we went through hip, and we went through foot. So my goal after all this, after having corrected all the areas that weren't moving well, is to have found my wow, indicating that I found the driver, the underlying cause of the problem, and the area where the intervention is most helpful. I then need to work out what's pulling the driver out of position or preventing it from moving properly, and that will help me to work out what to do with it so I can plan the treatment. So physio needs to assess the patient's meaningful complaint. So what are they feeling? Needs to address their goals and values. What do they want to be able to do? What's important to them? And it needs to help them restore optimal strategies so that they can do the thing that they want to do. But they have to be involved. I can't do that for them. I have to change their experience of their body because that helps them to buy into things, to the treatment process. And then I have to empower them to manage it. So I have to give them things that they can do to make their lives easier. And in every physio session, there's an element of reassessment because hopefully the driver will have changed, the symptoms will have changed, so the barriers will have changed. So we need to change what the barriers are, or release them first of all, and then spend the rest of the session focusing on retraining movement patterns. And again, I'm unusual in that my follow-up sessions last at least an hour, so I can get a lot of work done in that time. And what I'm doing in that time is I'm going through the 4 stages of rehab. So the first stage is to help the patient to recognise when their driver, the bit that we need to intervene with, is aligned, and to achieve this independent at rest. And that might involve some manual therapy, probably will, especially at the beginning, to desensitise and stretch the tissues in order to achieve an aligned position at rest. So I might, if the hip is the driver as well as the sensitised area, I might want to desensitise the hip flexors and then teach the patient the self-correction like I did with Liz, so lifting the ischial tuberosity and sliding the head of femur back into place. So that might be the first stage, is just teaching them how to do that at rest. The second stage is to add load and movement to the distal, the local structures, while maintaining control of the driver. So that might, if the hip is the driver as well as the pain generating structure, I might be trying to teach the patient to keep their hip aligned while they're moving their head and shoulders. So there's a little bit of challenge going on, but it's, nice and far away from it. And I might do that, or I might get them to, move their other foot or something like that, so that they're keeping the really proximal stuff aligned and the distal stuff, they're getting to move it. Then the next stage, we'll start into controlled movement of the driver. Again, if the hip is the pain generator and the driver, I'll be keeping the hip joint aligned within its axis. So I want to keep the head of femur centered while the patient is practicing stepping forwards or sideways or lunging or squatting or whatever it is that they want to be able to achieve. And then as we get further and further up the pyramid, if you like, I'll be adding load, I'll be adding volume, I'll be adding intensity, range of movement, speed, agility, perturbation. I'll be reducing their base of support, so moving from a wide stance to a very narrow stance, or onto one foot. I'll be reducing their input, so I might be getting them to shut their eyes or cover their ears or something like that, so that they can produce optimal movement in situations that are relevant to, but more difficult than what they require in their everyday life. So the idea is that by raising their ability to such a level, when they actually need to function at a slightly lower level, that their function will never exceed their ability. That's what we're after. So let's talk about a couple of case studies of patients I've actually done this with. So the first one is Emma. Emma's 45, she's a curtain maker. And when I met Emma, she'd undergone bilateral labral surgery, both hips. So she had the right one done 18 months before I met her and the left one 6 months before I met her. She'd been having physio all the way through and she was completely crippled, couldn't work, couldn't even think about working. She was taking neuropathics. You know, she was in a bit of a state. So meaningful complaint. So what was she feeling? Well, she was feeling pain, especially in her left hip when she was twisting, which was really important because that was one of the big reasons she couldn't work. Twisting's really important if you're using a sewing machine all the time. And that was her meaningful task, was to be able to sit at her sewing machine and twist. So when I looked at her in standing, her thorax was rotated to the right. So her left side was forward and it was side flexed to the left. So there was all this load going through her left hip. And so the load going through her hips was uneven and definitely not optimal. And when I corrected, and this is how we know it's the driver, when I corrected the thorax position, so I derotated and lifted that left side, when she was then able to sit, twist and lean without pain in her hip. So we knew that treating the hip was not the best thing to do here. When I put her hip in position, she still felt awful. But when I took the load of the thorax off it, her left hip felt a load better. So what did we do? Well, stage one taught her to recognize the correct thorax position, which was easy because she was like, oh my God, that's amazing. I taught her to reproduce it. So I taught her to use her hands to reposition her thorax. Then we taught her muscles to do it. And then we gradually added more and more challenge until she could manage being at her sewing machine, but she could also manage, other things. She could go up and down ladders. She could, touch her toes. She could touch her toes and twist. She could pick up rolls of curtain, fabric and stuff like that, so that everything she needed to be able to do in her job, she could do comfortably. And, it worked. It took a little while. It did take about 4 months, but she was able to get back to work full time and to get back on with her life. Next one is a guy called Stephen. He's a 58-year-old marketer, keen runner, ex-military, no prior history of any injuries, to be honest. But he came to see me when he had pain when he was loading his right hip. He was very keen on running. And he'd also realised that he couldn't put his right sock on easily and he couldn't cut his toenails on the right foot. So his screening tasks, the building blocks of that, is being able to transfer weight onto the right side, step forward onto the right foot, and right hip flexion. When we looked at those movements, we realised that he had a real sort of, turtle position. So his head was way too far forward. And what that does is, there's a big old moment arm. The muscles of the neck and back are then overworking massively to stop him face planting because his centre of mass is way too far forward over his base of support. And it seemed to be really affecting his right glutes. He wasn't really able to fire his right glutes at all. So we got him in a better head position, and suddenly his right glute started firing a lot better. So that was reassuring. So the first thing we did with him, again, start to recognise the correct hip position, neck position, loads and loads of stretches because the tissue was really tight in the suboccipital area. So we did a lot of manual therapy and stretching, and then gradually taught him to maintain that position when he was walking, when he was touching his toes, when he was running, and he gradually did improve. Now, he improved quite a lot for the first year or so, and then his symptoms started kicking back in. So eventually he did need a hip replacement, but he carried on working on his neck, he carried on working on his glute activation functionally, and so he had the hip replacement in December. He's now made a full recovery. He's back to running 10K, several times a week. He did a 25-mile walk this weekend, and I think he did his last 10K in about 42, 43 minutes. So that's pretty impressive for 58 with a hip replacement. So pretty chuffed with him. And then the last one, this one is a different one. This is Ella. She's 23. She's a fashion buyer. And she came to see me with right anterior knee pain and an MRI of her knee that showed that she had some retropatellar cartilage damage. So she was sent to me by a knee surgeon with pain in her right knee when she was walking. But when I assessed her, I looked at her weight transfer onto her right foot and realised that when she was loading her right leg, her right hip was really poorly controlled and her femur was internally rotating and it was very, very jammed. So I started off by doing the hip corrections that I did with Liz, so lifting the ischium, realigning the head of femur in the acetabulum. And I could get some correction and I could relieve her symptoms a bit, but we couldn't. After a session or two, I was going, I think we need to get this hip scanned. So we scanned the hip and we found an acetabular stress fracture, which, you know, deep joy. Really glad we found that. So we then offloaded her on crutches for 6 weeks. We've gradually been working on proprioception, motor patterning, building up her ability to load that leg again. She's still undergoing treatment. We only did the MRI about 4 months ago. But the important thing is that because we didn't just home in on the knee, we've actually found the underlying cause, which is the hip. And so her hip and knee will now have a chance to actually make a recovery. So in summary, what we've looked at today is we've looked at the difference between how surgeons and physios look at the body. We've looked at different models of looking at the body, whether that's the biomedical model, which most people use, regional interdependence, which I think is probably the next way that people are going to hopefully start looking at the body. And we've looked at my health and performance pyramid, which is, you know, regional interdependence with all the bells and whistles. We've looked at some of the evidence and how that stacks up for all this stuff. We've looked at clinical relationships and we've looked at hips. I want you to bear in mind that what I've talked about today is very much not how all physios work. It's very much how I work after 20 years of practice, a lot of non-standard training and a lot of non-standard experience. And I can't urge you enough, get to know the physios you work with, learn how they work, let them learn how you work so that treating patients becomes a collaborative experience. I'm incredibly grateful to the surgeons, the sports physicians, the radiologists, the pain consultants that I work closely with, as I have learned loads from them in the last 10 years in private practice. And I like to think it's a two-way process because I've got my own ways of looking at the body, as you've seen. And if we all talk together, this is something that our patients can really only benefit from. So thank you very much for your time today. And if you have any questions, this is how you can contact me.